Well, welcome everyone. Welcome to Mitigating Medical Mishaps. Tonight, I'm going to be your host, Greg Caldwell, but we have my partner, Joe Sowka, from Center for Sight USI, doing our presentation for us, Mitigating Medical Mishaps. I think you're going to see that this is one of Joe's expertise, kind of helping people talk off the ledge. If you ever get that letter, it's probably a good resource to reach out to Joe, have him talk off the ledge. Joe, I think everyone knows Joe as a professor at Nova Southeastern. I think, Joe, you were there for 28 years in one day.
And 2 days.
Oh, 2 days. Sorry. We got to update that. 2 days. Joe is currently working for Center for Sight in Sarasota and Venice. This is a large glaucoma and neuro-ophthalmic disease, or this is a large medical surgical practice, and Joe focuses on glaucoma and neuro-ophthalmic disease. Joe is also a founding member of the Optometric Glaucoma Society and Retina Society. He's also the former chair of the Neuro-Ophthalmic Disorders and Special Interests Group for the American Academy of Optometry. He was ranked number 4 optometrist by U.S. Newsweek magazine in 2021 and 2022. But that wasn't good enough for Joe. So in 2023, he was ranked number 1 by U.S. Newsweek rankings. Joe is a great partner. He's a co-owner of Optometric Education Consultants. Joe, I think I hear it. It's your round of applause. Please welcome Joe to the virtual platform.
Well, thanks a lot, Greg. Thanks for the intro and getting us started. This is something I have some experience with in terms of mitigating medical mishaps and malpractice. And we're going to be talking about common preventable, potentially preventable errors that can occur. Now, this is my disclosure. I am on the advisory board and speakers bureau for Bausch Health, Bausch & Lomb. All relevant relationships have been mitigated. There's no products that are going to be discussed in here. And this presentation is my own creation. So that's my formal disclosure. I think I should give you a further disclosure. Nothing stated during this lecture should be remotely construed as being fair or reasonable. I think you'll see what I mean in just a little while. So I'm going to start off with a couple issues. Common preventable causes of potentially catastrophic patient injury that we have to be aware of. So misdiagnoses, or is it malfeasance, things that I have come across a lot. And in terms of working in medical malpractice cases as an expert witness, I've done probably 150 to 200 cases at this point. I've never really kept track. I think I've got about 3 cases active right now. So what do we need to be aware of? A couple things that are particularly onerous. Giant cell arteritis. It's so varied in its clinical presentation that there's plenty of blame to go around. This is actually one of the top cases in ophthalmology and neuro-ophthalmology. Posterior vitreous detachment with subsequent retinal detachment. Just because a patient develops a retinal detachment does not mean that the optometrist should be sued, but unfortunately often are. Infectious keratitis, sometimes it comes down to a simple failure to consider what else can it be? I'm treating it for one thing, but can it be something else? And we have to balance the time needed to get a therapeutic resolution versus sometimes going too long or going down the wrong diagnostic and therapeutic path. And remember, infections change appearance over time. Early cases are hard to detect. Optic atrophy is a term that's used too cavalierly. If you don't investigate it or explain it, you might as well write down on your chart, I think the patient has a brain tumor. I'm going to choose to do nothing about it. The eye not correctable to 20/20 should be investigated. Patients with unexplained or unresolved symptoms, we need to run them down and do a little bit extra. And I will tell you, doing a little bit extra is very important, because I had an epiphany not that long ago. I thought and I thought and I thought, and I cannot think of a single case where an optometrist being sued had done a culture, had done blood work, or had done neuroimaging. It's always the absence of doing a little bit extra that creates some issues. 74-year-old male presents with the worst headache of his life. He goes to the ER department, emergency department of a Veterans Administration hospital. He sees a physician assistant who is overseen by an emergency department physician. She diagnosed temporomandibular joint dysfunction, despite the fact that he could fully open his mouth. The physician supervising, I'm not sure if examined or just signed off. Patient was given an NSAID. Now, the patient didn't do so well. Over a 3-week period, came back several times where he saw not only the PA and the ER physician, but a cardiologist, a nurse practitioner, and 3 optometrists. Now, when we look at the overall case, we find in his histories at various times, keep in mind these are all available in a medical record, he complained of eye ache, jaw pain, scalp pain, facial pain, somnolence to the point he fell asleep while eating, malaise, and jaw claudication. Now, his headache did not resolve. He comes back. They find a tick on him. Now they diagnose him with Lyme disease and put him on an antibiotic. And in the chart, here is written in 2 different places, vasculitis such as temporal arteritis, highly unlikely, not GCA. However, SED rate and C-reactive protein were ordered. Both came back elevated. It's never clear that anybody ever acted or reviewed on these findings. Ultimately, an optometrist made the diagnosis, but it was too late. He went bilaterally blind from temporal arteritis. 72-year-old female, 6-week history of scalp pain, fatigue, weight loss, and transient ischemic attacks in the right eye. Goes to an optometrist with sudden vision loss in the right eye. At this point is no light perception right eye, 20/20 left eye. Diagnosis papilledema right eye. Plan referred to ophthalmology next day. Next day goes to ophthalmology. Is now no light perception in either eye from an arteritic anterior ischemic optic neuropathy in each eye. 68-year-old female, 1-month history, sore throat, cough, ear pain, all unresponsive to antibiotics. Suddenly loses vision right eye. Neurologist diagnoses a Horner syndrome. That didn't explain vision loss. Refers to ophthalmology, who diagnosed a central retinal artery occlusion, said, you've had a stroke in the eye. There's no evaluation or anything that we can do for you. 1 month later, she suddenly loses vision in her other eye, and when a better history is taken, we find she was not eating for 6 weeks prior to the initial visit because she had pain while chewing. Now she's no light perception left eye with ischemic neuropathy. She has a pupil-involved third nerve palsy, hypotony, and the right eye still has a Horner syndrome and an old artery occlusion. Labs were run. SED rate was markedly elevated. She had a temporal artery biopsy that was positive. She was diagnosed with giant cell or temporal arteritis. Put on steroids, high dose immediately. She felt better. Symptoms went away very quickly, but she had no visual recovery. 78-year-old female, 1-week history, occipital and jaw pain. Family practitioner treats her with NSAIDs. 2 days later, she has 1 hour total vision loss in both eyes, midnight in a coal mine. After an hour, the right eye recovers, left eye does not come back. Family practitioner immediately discontinues NSAIDs, refers urgently to ophthalmology. Ophthalmology triage said, it sounds like an NSAID reaction. Wait a week for the NSAIDs to wear off before coming in. Unfortunately, she didn't make it that long. Next day, she was blind in the other eye with a markedly elevated SED rate. So one way to always avoid this mistake and mitigate this issue, this medical mishap. Always remember, any acute vision loss in the elderly is giant cell until proven otherwise. Now, what is the definition of elderly? It's 50 and above. That's not my definition. That's in the medical literature. You pick up any manuscript in a peer-reviewed journal talking about temporal arteritis or arteritic ischemic neuropathy, I can virtually guarantee in the first sentence of the introduction will be something to the effect describing it as an autoimmune vasculitis afflicting patients over the age of 50. So always remember that. Greg, that brings me to polling question number 1. Which is worse in patient management, to be wrong, or to be negligent, or they both seem pretty bad?
Polling question is open. There are no questions other than someone's going to look up draconian.
Draconian. Draconian, very, very harsh and rigid. Flinty, unwavering. That would describe my state, Florida. So what's it worse, to be wrong or to be negligent?
The
Or are they
answers are
both
rolling
equally
in,
bad?
Joe.
Or are they
Just so
both
you know,
equally
the answers
bad?
are rolling in. Remember, everyone, you just look on the right-hand side. It says chat, polls. Click on the polls, and the question should be there.
No
All right.
NBEO type questions. These are all going to be mostly opinion questions. What do we say, Greg?
Well, we have one person saying to be wrong. The majority, 79%, saying to be negligent. And you have 20% saying, they both seem pretty bad to me.
That's all very reasonable. I mean, doctors are allowed to be wrong. You can mount a defense of being wrong, but it's when it's negligent. The word negligent or below standard of care are golden words in medical malpractice. If those can be entered in and agreed upon, it's really going to be pretty bad. Now, here's a patient of mine. Saw her probably a couple months ago. Routine examination. I've seen her before. Nice woman. And during the course of her examination, she mentions, not chief complaint, but she mentions intermittent right scalp pain. Tells me it happens in the morning, dissipates throughout the day. Happened already that day, already dissipated. She felt fine. Her exam was completely normal. Now, I actually thought about this. I wrote in the chart, doubt GCA or zoster, but will obtain serology. And I pulled the blood, or I had the blood pulled, and her SED rate and C-reactive proteins were both markedly elevated. Worked with her PCP, got her on a high-dose prednisone, and often referred to rheumatology. And remember, giant cell arteritis is the most common chronic adult vasculitis. It is out there. And sometimes there's a milder form called polymyalgia rheumatica. This is a disease that can actually have exacerbations and remissions and can go really quite a long time before it's diagnosed. Now, if I had assessed this and did nothing, I would have been wrong if she had lost vision. Maybe she wouldn't have lost vision. But if I ignored it altogether, one can argue negligence. Here's another case. It's a case I'm working on right now. Patient complains of vision loss in the right eye. I think this was a 71-year-old male. Now, patient is 20/20 in each eye, but still felt the patient he still felt he had bad vision in the right eye. Pupils were normal, discs were normal, exam was normal. Mentioned temporal pain on the right side in the history. The OD did assess him, but he felt it was very nonspecific and didn't really detail it at all. And ultimately, the patient lost vision from an arteritic anterior ischemic optic neuropathy in the right eye and giant cell. And this was kind of a festival of errors. I'm not sure where this is going now, but I think it's eminently defendable. Did see an ophthalmologist who did suspect giant cell as well as a lot of other things that are kind of weird. Made some recommendation for some orders and blood work that they weren't carried out urgently. Patient ultimately did end up in the hospital and was in the hospital for 3 days before a neurologist finally diagnosed giant cell. So there's a lot to spread around on this one. So remember, giant cell arteritis is the most common chronic vasculitis in adults. You should always lower your threshold for testing for this disease. Testing, very simple, sed rate, C-reactive protein, and platelets. I do it all the time. I write out the note, I print out the note for that, give it to the patient. I use some of the Quest or LabCorp, some of our local labs. Doesn't have to be fasting. You can get it done. If you don't hear from me in 2 days, call me because it means I didn't get the results yet. Diagnosis delay in cranial arteritis, meaning involving something in the visual system, is about 8 weeks, 7.7 weeks. Now, in non-cranial giant cell, and they have muscle aches, they have fevers of unknown origin, night sweats. The diagnosis delay is almost 18 weeks. So this is something that lingers and it is out there. So if you look at the clinical presentation, you've got numerous things: constitutional, fever, night sweats, fatigue, depression, chronic dry cough, loss of weight and appetite, stiffness of the neck, shoulders, pelvis, proximal muscle aches, which are worse in the morning, exacerbated by movement, new onset headache, scalp tenderness, claudication of the jaw or tongue or the extremities. And it's usually more the upper than lower extremities. And that's what I want you to really concentrate on, is those symptoms up there in the upper left. If we hear those from our patients, we need to assess it some way, either acknowledge it and decide it's non-specific and not pertinent, or we need to test for it. Visual, ischemic neuropathy, cotton wool spots, sentinel artery occlusion, cranial nerve palsy, and diplopia from extraocular muscle ischemia. These are all very common type of presentation. So it's highly varied. Look at this. Take a picture of this if you're so inclined. Take a look. Look at this, and whenever patients mention these things, they can have a completely normal exam, but consider giant cell arteritis. Now, if you're ever wondering what to do in a case, or how much you should get involved, or is this something I should deal with, read the chief complaint to yourself and see if your actions are justified. If you can say, I've got a 78-year-old female here for routine eye exam. She mentioned some itching and mild dryness, which clears when she blinks. She feels her vision is off a little bit and wants to have her glasses checked. She also mentions having headache that began about 2 weeks ago and has been intermittent but every day. Bing. If that's in the record and you don't assess it in some way, and this is actually giant cell arteritis, and the patient goes on to lose vision, this is going to fall into the category of potential negligence if it's there. Now, it's one thing the patient doesn't tell you. It's not in the history. And I don't think anybody can fault you for missing something like that. But when they mention it, acknowledge it, decide, is it pertinent, is it not pertinent, and test for it, or ask, phone a friend, what should you do? Anything come in the chat, Greg?
Not yet, but let me double check because I had the polling question ready. Let me take a quick look. Let's see. Did I receive the last polling? I won't be able to tell that, so I can't tell, but if you found the polling and clicked on it. Let's say you order testing, but vision goes before the results are in, or they come in and you can't immediately reach the PCP. Can you be held responsible?
The answer is, unfortunately, yes. Now, would you be negligent? Well, not necessarily. You've recommended or ordered the blood work. If your actions are reasonable, it is hard to fully fault one for a case that goes badly quickly. Usually what I find is, and as I showed you, with the delay in diagnosis, you generally have time. When you don't have time is when a person has had an artery occlusion or ischemic optic neuropathy in one eye. Means we've got very active disease, and there's a 65% chance that the other eye is going to be involved on an average of 10 days. So that means we have to get involved. And if you need urgent help and you can't get the PCP, there's always a hospital emergency room if you're willing to share with them what your thought process is and what they should be doing, what you're considering.
You are all caught up.
Now, let's talk about another one that I see a lot of. We all see this, but I see where this often goes, unfortunately. The acute PVD. I think probably everybody here, if they're seeing on this webinar, if they see patients clinically, do see patients with acute PVD. When a patient comes in with that acute vitreous detachment, when they come in, understand there's a 15% likelihood there's a retinal tear. So that's where we have to do a thorough, very thorough peripheral examination. And if they have one tear, half those patients are going to have more than one. Or if there's a tear, they have more than one tear. Now, I think everybody out there has some sort of gestalt. They like to repeat the examination. They look, they see nothing, so they bring back. Now, I like doing this live when I can ask people, how long when do you repeat the examination? And I always hear 2 weeks, 4 weeks, 6 weeks, 3 weeks, 8 weeks, and there is no consistency. So there is no standard as to when to do it. But statistically, most retinal complications from a PVD occur within the first 6 weeks. About 3 to 5% of patients who don't have a retinal break at initial evaluation will develop a late onset break. Now, we say 6 weeks. Yeah, I will tell you from my secondhand knowledge, looking at these cases where a PVD has occurred, no break was seen, and the patient ultimately does undergo retinal detachment. Most cases I've seen have progressed within 1 to 2 weeks. So if you're bringing a patient back 4 to 6 weeks, I would probably urge you to bring the patient back a little bit sooner. I am generally doing somewhere in that 1 to 2 week. You can also do another follow-up if you're still concerned. But if no complications develop within 6 weeks, at that point, routine follow-up is indicated unless the symptoms change. Now, there is some literature out there that says that this routine follow-up is likely unnecessary and should only be done if there is an increase in symptoms. All right, that's great. That is literature, published, but not everybody has adopted this philosophy, and I would not recommend that you do that either, because the majority of optometrists, when seeing acute PVDs, routinely schedule a follow-up dilation, at least of the involved eye. And if that's what most people do, that is standard of care. Now, here are a couple of things I want to point out, some cases. Here's a nice Weiss ring right there. That's the optic nerve. This is a beautiful example of a Weiss ring I saw several years ago. And by nature, the vitreous is clear. And these are sometimes hard to find. As I say, it's like trying to find a ghost in a cellophane factory. So you want this to be clear. Now, you may have seen some pigmented areas here or darker areas. Maybe it's a little cloudy. Right? That's not pigment, that's blood. All right, that's a hemorrhagic Weiss ring. And that is going to increase our suspicion level and make us look a little bit more carefully, maybe do a little bit more and maybe record a little bit better, because it should be clear. If you see what you think is pigment in there, there's no pigment that's coming from, that's blood. You can see some blood, hemorrhagic Weiss rings. Now, what I think is probably the most important view is the inferior mid-periphery. See in these two different patients, this linear hemorrhage. These are after PVDs, two different patients. And by nature, it's settling out. And that's where it is pre-retinal. We have a little bit of blood here. That is also going to increase our suspicion that there might be a retinal tear that we need to look for. Now, here's something that I have seen several times, many times. I examine patients initially upright. You know, I'm standing, they're seated, and I manipulate their head. All right. I can see that hemorrhage. I'm going to look again. I'm going to recline that patient. And in virtually every situation where I've done that, when I recline the patient and repeat the fundus examination, I cannot find the hemorrhage. It now spreads out. I sit them back up, wait a minute or two, I'll look, and the hemorrhage will reaccumulate. So how you examine them is actually kind of important. So now when you count, and also the hemorrhagic Weiss ring and this little bit of pre-retinal hemorrhage here, all right, that might be in an eye that does not have a break. A lot of times this little bit of blood here and here will be from torn disc capillaries. That doesn't mean there's a break. So when you see blood, it doesn't mean there's a tear in the retina or blood vessel has been torn, unless you see significant vitreous hemorrhage that prevents you viewing the fundus. That's most likely a tear, but these little bits of blood most likely are torn disc capillaries, and there is no tear. But you got to look at them really carefully. Acute PVD with any vitreous or pre-retinal hemorrhage, but no discernible break. And this means you're doing things like 3-mirror lens if you have that ability, non-contact 90 looking, BIO, scleral depression, consult a psychic, whatever you need to do. You need to watch these patients very carefully, probably every week to 2 weeks, or get a second opinion. I don't think any reasonable retinal specialist would object to looking at that as well, but she or he may not find anything either. Now, if I don't see a break, I will re-examine them at regular intervals until the hemorrhage clears every 1 to 2 weeks. Make sure. I'm probably going to do 2 more fundus exams on this patient. If there no breaks are found, it's probably just superficial capillaries that are ruptured from the PVD. Now, small amounts of inferior hemorrhage, a little bit of blood on the Weiss ring, yeah, that could be torn capillaries. Larger amounts of vitreous hemorrhage, there probably is a tear. But record everything that you do, the drops you use, the lens you use, that you saw the Aura 360, if you did, scleral depression, if you did it. How did you examine? Did you examine them upright or supine or both? The best thing you can do is a good record. Now, this is an example of a case that I had. Up here, you can see fluoresce, tropicamide, phenylephrine. Very good. I like that. Down here, lenses used 90 and 20, scleral depression 360, examine upright and reclined. That's very detailed. Now, I could have written down saw Aura 360. Maybe I didn't. Maybe that's why I didn't write that down. Posterior vitreous detachment. What don't I see? I don't see vitreous hemorrhage. I don't see cells, but I do see some white without pressure out there. The hardest thing to defend is an incomplete record. The worst thing is when I have to ask an attorney to go to the doctor and please tell me, what did you do? I don't know what you did. Here, the record is going to speak very well. I can tell you, I had a period where I had several hemorrhagic PVDs in the same week. It was just it seemed like a bad week. Saw several hemorrhagic PVDs, just a little bit of hemorrhage on the Weiss ring, a little pre-retinal hemorrhage, examined them periodically, never found a break. Now, there is another patient who has been seen by another doctor in our practice, but he could not see the patient on follow-up. So he scheduled the patient with me. This is a person who had an uncomplicated PVD, no blood, no problems. In fact, when he came in, his symptoms were gone. No flashes, no floaters, everything was great. When I dilated him, first thing I saw was a big flap tear. So don't get lax so we don't have an issue here. Now, here's a case I call snatching defeat out of the jaws of victory.
Hey, Joe, can you hold on one second before you move on to that?
I probably should have breathed and probably should have taken a question. Go right ahead, Greg.
Yeah, no problem. We have a question about PVD. At the follow-up for a PVD, do you routinely dilate only the involved eye or both eyes?
I routinely only do the involved eye unless they tell me something about the other eye. Because when they come in the first time, I've looked at both eyes, I see nothing. They're coming back for that PVD. It's a great question. You're not wrong to do both. Usually, I cut the patient a break, and I only do the involved eye. That's a really good question.
You were all caught up.
All right. So this is a malpractice case. A patient presented with reduced vision of 20/50, and this was an old case. I will tell you, statute of limitation is 2 years from the event, the exam, whatever it may be. The patient has a window of opportunity to sue or file suit of 2 years. Now, once something has been filed, it can go on indefinitely. The longest case I was ever personally involved in went 8 years. The other caveat to 2 years is except when it's a minor. If it's a minor, they have up to age 18 plus 2 years. So a minor has a longer window of opportunity. Now, I don't understand why they don't just say 20 years, but they say up to age 18 plus 2 years. Okay. This case was 15 years old, which is long even, by these standards. But what happened is the optometrist diagnosed central serous choroidal retinopathy based upon an OCT, but didn't dilate to confirm the finding. Ultimately, it goes to trial. It turned out to be a retinal detachment. Went to trial, and the optometrist prevailed. But they had a poor expert witness for the plaintiff. But there was a technicality, and the verdict got overturned, so I had to go through trial again. So they wanted me to now be the expert witness, and it goes into litigation. And I agreed to try to defend, and then they send me the records. One of the first things that pops up was, and this is just representative image, is an OCT that looked like this. And clearly it was a retinal detachment. And I had to decline and said I didn't feel comfortable that we could prevail or go forward on this. But I asked, what happened? How did you win the first time? He said, well, their expert witness wasn't really good. OCT was relatively new at that time. And what happened was they pulled, from the patient's case, they pulled a cut of the OCT that looked like central serous. They showed the jury an atlas of OCT images of central serous. It looked the same to the jury. They said, no, that's what the diagnosis was. But when when you look through and see this, I really could not move forward. Here's another case I was asked to defend, and ultimately, this was an OCT RD case. I was asked to defend the optometrist. Patient complained flashes and floaters, has 20/30 vision. They do an OCT, and it shows a large nasal mass, and the working diagnosis was the patient had a melanoma. Now, unfortunately, the optometrist, again, this different case, did not do a dilated fundus exam, just went with the OCT. Try to urgently refer the patient to local specialists who wouldn't take the case because they weren't ocular oncologists. So it ultimately got the patient into a major metropolitan teaching hospital about 2 weeks later with an ocular oncologist who examines the patient, finds now an extensive regmatogenic retinal attachment. The patient now has light perception vision, and there's no evidence of tumors. Now, what do the records of the OCT show? I'm trying to defend this, and I'm looking through, and I think this is probably fairly, possibly reasonable. And I always hate these Optos and these wide field image cases because, the quality is never really any good. I'm looking at a PDF, and I don't have real image, and I'm scrolling through the chart. There it is, a nice, beautiful regmatogenic retinal attachment with a flap tear, and it was right there in the record. So I could not go forward on that case. So don't just go by an OCT or any diagnostic test. Actually examine the patient. Now, if the doctor thought it was a melanoma and examined the patient, could that person maybe have changed their opinion? I don't know. But always examine the patient. Just don't go by the diagnostic technology. Don't diagnose glaucoma off a visual field alone or off an OCT alone. Actually examine the patient. Now, I always say it's the economy. Well, it's the record. The record is it is your clinical guide, and it is your only defense, to be honest with you. The worst thing is when I try to defend the case, and there's only a few words on it. Now, electronic records are making things a little bit easier, but we still have some challenges. Handwritten charts are often very much the challenge. Now, I was asked to opine in defense, and I guess you can say I was misled by the attorneys. I said, this is in the defense. And they said, yes. Well, the patient was incarcerated. He was a guest of the prison system, and the optometrist was an independent contractor who went into the prison system and examined patients. Not an uncommon thing to do. And apparently the patient developed a retinal detachment, and the Department of Corrections and the penal system was being sued, and I was actually defending them, and what they wanted me to do was opine against the optometrist, and I thought I was defending the optometrist. Well, let's take a look at this. I've redacted some names, but this is about the extent of the chart. And if I go through here, I count about overall 13 words. Now, do you want to go into court with a record that only has 13 words? And ultimately, they kind of had just enough. And it comes down to what's circled right down there. And we can see that the doctor had written their follow-up ophthalmology, evaluate OS, and we see something there. And I don't know if anybody can make out what that is. Can you tell what that says, Greg?
I was trying to figure it out. I cannot.
Okay. I was able to figure it out, and it says macula. Not very clear, but it says macula. And why can I figure that out? Because I'm an eye doctor. We're eye doctors. I think people could probably figure this out. We know kind of what could be there and what should be there. Now, I can tell you in the prison system, because I worked there as a doctor, an independent contractor at one time, many years ago, early in my career. And it's not like you can write a script and send them off to the pharmacy or ask, what pharmacy do you like to use? It doesn't work that way in the prison system. Everything is overseen by a medical director. If I prescribe anything, it has to be on a prison formulary. If I prescribe a drop to be used 4 times a day, the guards have to take that person out of the cell down to a nurse's office 4 times a day for a nurse to put a drop in that person's eye. And I can tell you, I would get called if I prescribed something that wasn't on the formulary. It's always very nice. Is there anything else we can use? We don't have that available. And we would work that out. Or they would say, 9 times a day, do they really need to be, getting drops of that? The medical director would call me. So a medical director is an internist, and should that person know what that word is? The answer is no. What should that internist have done? Picked up the phone and called the optometrist to find out. And then there would not have been a 6-week wait to get the patient out to an outside ophthalmologist. So eventually they had to acknowledge their culpability. Anything going on in the chat room, Greg? And out there in the audience, please, if you have any questions about this or situations, put it in the chat room and I'll be happy to answer it.
Nope. Your last question was about the PVD and dilating the involved eye or both eyes. So we're caught up.
All right. Well, let's look at some optometric malpractice. Is it fact or is it fiction? Let's talk about what is malpractice. It's a dereliction of professional duty or failure to exercise an ordinary degree of professional skill or learning by somebody such as a physician or attorney, rendering professional services which results in a permanent injury, loss, or damage. It's an injurious, negligent, or improper practice. That's malpractice. Now, what happens as an expert witness? Like I said, I don't know how many cases I've done, 150, 200 cases. I don't know. I mean, they come several at a time. I probably have 3 active cases right now. So what do I do as an expert witness? Well, I've got to be able to handle an adversarial situation. When I am being deposed, I am going to be treated only marginally better than the doctor who is being sued because they want to discredit me. They want to use anything I say to lessen my impact with a potential jury. So it's always going to be it's cordial for the most part. It's not often confrontational. It's cordial, but it's adversarial. Depositions are interrogations. Yeah, it's important to be fair and objective. If a patient has been wronged, I think they do deserve redress. But I don't want to see a doctor suffer for what may have been the natural outcome of a disease process. And balance is important. When I'm deposed, I'm asked a series of questions that I have to answer. First question I'm going to get asked is, have you ever done this before? The answer is yes. Has your opinion ever been disqualified in a court of law? The answer is no. Do you advertise your services in illegal journals or magazines? The answer is no. Do you charge a fee for your services? The answer is yes. Do you keep the fee that you charge? The answer is no. My wife gets it. And they're going to ask me, for whom do you testify? And if I were to say 100% of the time I testify for plaintiff against doctor, or 100% of the time I testify for defense optometrist, I'm going to be portrayed as being biased. Now, the vast majority of what I do is in defense. I will take plaintiff's cases. There have been situations where I've taken plaintiff's cases, I've looked at it, and I've gone back and I'm told the attorneys, the doctor met the standard of care, there's no case here. And they can either choose to relieve me of my duties, or they can, not proceed forward. And there have also been balanced out by a number of cases where I've been asked to defend, and I felt that it would be inappropriate to do so based upon the case. Now, this is not high courtroom drama. This is all about educating the attorneys. They don't know the eye. Their words, not mine. They know kidney disease, they know cancer, they know stroke, they know heart disease. They don't know the eye. There just isn't a lot of money in the eye. Now, I have been involved in cases that have been big money, but for the most part, they're not. They're not big money cases. They're things that get settled. In fact, I was on a plane reading a deposition one day. I didn't know. I was sitting next to an attorney, saw what I was doing. He engaged me in conversation. And when I was, told him what I was doing, he said, "Wow, I've never heard that before. I've never heard of an eye case. I didn't think they existed." He goes, "There's no money in the eye." So mostly just educating the attorneys about the disease process and standard of care. And I always believe that whatever the opinion is, it should be the same opinion, regardless of which side you're testifying for. If I'm testifying for the defense and I have an opinion, I should look at it. What if I were testifying for the plaintiff? What would I say? It better be the same thing. Common errors when expert witnesses try to win the case. That's terrible. People will impugn themselves. They'll do ridiculous things. It's not my job to win the case. I was defending an optometrist who allegedly had missed a retinal detachment. She did a very good job. She examined the patient, did BIO, scleral depression, everything. Right? PVD, no complications, set the patient for a follow-up. Now, before that follow-up occurred, patient got something in their eye, possibly a chemical injury, came in and was examined by the optometrist and was not dilated because the patient came in for something else. Now, The record said patient came in for a chemical or some sort of work-related keratitis. The patient says, no, they came in because their symptoms were worse. Well, regardless, the doctor did not dilate on the second visit, and the patient ended up having a retinal detachment. Now, I told the attorney exactly what's going to happen. I'm going to be asked under oath in deposition, was it necessary for this optometrist to redilate an eye that got supposedly a chemical keratitis? I'm going to tell you the answer is no, that's not necessary. And I told the attorney, so I can guarantee that in cross-examination, the plaintiff's attorney will say to me, Dr. Sowka, suppose a patient with a PVD comes in with worsening symptoms. Should that patient have been dilated? I can't equivocate. I'm not going to haw, well, maybe, sort of, it all depends. I'm going to say yes, if that's the case, that person should be dilated. Any reasonable paralegal can find things that I published in the literature that says that. So I can't say anything that's equivocal in that situation. And I told her, it's not my job to win the case. It's your job to make your client more believable than the plaintiff. And another thing is thinking you must go all the way through. Just because I'm hired by somebody doesn't mean I have to see it their way. And I've been released many times because I don't feel the case. Here's a retinal attachment case where I was in defense of the optometrist. The patient complains of floaters. Examined by an optometrist who dilated, did VIO, found the retina intact, warned signs and symptoms of retinal attachment, to return ASAP any changes, and probably did schedule a some week follow-up. Anyway, patient experiences vision I think this was on a Monday. Patient experiences vision reduction on a Thursday. It's worse on Friday. Wants to wait to see if it will clear up over the weekend. Comes in Monday with a macula off retinal attachment. And sued the optometrist. Now, they had an expert witness, another optometrist, against the as the plaintiff's expert witness against the OD. And when it was, this optometrist said the examining OD was negligent and did not do a proper examination. And the attorney said, well, he dilated, did indirect ophthalmoscopy. What more should he have done? He did look, did he not? And the actual words she used were, he didn't look well enough. And that is just irresponsible. And I hate to say it, there are people out there that will say anything. Now, here's some important patient considerations. I'm going to say the vast majority of the cases that I've been involved in, where an optometrist has been sued for malpractice, it involves just one visit. And I can virtually guarantee, unless there is something egregious or very, very unusual, you're not going to remember that one visit. It's all going to come down to the record. I can't say that a week doesn't go by where a couple times in a week, I'm just examining a patient. Maybe I'm doing BIL, and I think to myself, if I missed something or something went wrong, would I remember this examination? The answer is absolutely not. I would never remember. So everything we need to have, needs to be in the record. Now, some patients, have been legitimately wrong. They deserve redress. Sometimes patients are angry and they're looking to blame somebody. I've always taught my students and residents, you should never ascribe your values to other people. You're different, you're special, you're a professional. Not everybody is the same as you. I do think the economy does enhance malpractice claims when people are hurting. They're looking for some sort of remuneration. And patient depositions are mind-numbingly boring because it's the assessment factor. A lot of these patients are not especially well educated or articulate. but they're mind-numbingly boring. One reason is it's an assessment factor. How will the patient play before a jury if it goes that far? That they always consider what would it look like in front of a jury, because all about assessing. Also, they're trying to get information from the patient, meaning that they may start going slowly. Then they build, patient gets comfortable. They start asking about all their loss, all the things they can't do. They can't ride their bike. They can't use their computer. They can't do this. They can't do that. All the while, the patient has already been filmed or videotaped doing all of these things. That's why they have private investigators, not just for philandering husbands. Now, patient complaints that I hear a lot of: vision loss, field loss, loss of ability to lead a normal life, constant dizziness from vision loss or field loss, intractable headache from vision loss or field loss. I was approached by an attorney to opine against an optometrist for a plaintiff, for a patient. And it was a retinal detachment case, and they went through it all, and it was somewhat local in my area-ish, my part of the country. And I said, I don't know the optometrist. I don't think I know the optometrist, but I would prefer not to get involved, so I'm not going to take the case. And he goes, that's all right, I understand. And I told him, but if defense calls me, I will probably take the case. He goes, that's all right, that's good. But I said, I will give you some advice. He goes, okay, what is it? Said, is your patient complaining of headache? Yeah, he's got a terrible headache from his vision loss. He's lost visual field. He's got an intractable headache. He can't work. He's always dizzy. And I said, your client is lying to you. What? Headache, dizziness, great symptoms. Any juror can understand what dizziness is and what a headache is. There is no medical substrate that explains it. Even a person with vision loss or field loss, they have intractable headache or dizziness. Any patient that says that, I know they are lying. I totally turn and say, your client is lying to you. Hey, Greg, this pulls me to polling question number 2. If an attorney thinks there's been negligence, can he or she sue you for malpractice? Is that fact or fiction?
Polling question is open. No new questions in the chat box. No new comments.
Are we doing okay, Greg? Everything sound all right?
Yeah, sounding good, doing well. Polling
All
question is open. We got some people replying.
So if an attorney thinks there's been negligence, that person can sue you for malpractice. Is that fact or is that fiction?
It was a little slow getting started, but now the answers are rolling in. So remember, everyone, the polling questions, right-hand side, you'll see chat, you'll see polls. If you click on that, it should open up to the polling question. All right, Joe, I'm going to display it.
All right.
We've got 72% saying fact.
Okay.
73 now, 73% saying fact.
All right. That's fiction. It's fiction, as Ringo would say. No, they can't. Just because they want to sue you, they have to have a medical professional opine that there is a reasonable suspicion of negligence. An attorney can't do it. All right. They have to hire a medical professional to do that. Now, here's a caveat. Attorneys will give you a subpoena for your records. You have to provide them completely and provide them promptly. Usually they have a window in which to respond. That window is usually 10 days. Now, if you do not produce your records within a reasonable amount of time, then they do not have to get a medical professional to opine that there may be negligence. Then they can sue you because they want to. So if you're subpoenaed for a record, just give them complete. Don't change them. You'll be fine. Here's a case I was asked to be the initial medical specialist against for the patient. Is this a patient that, is this a case that, where the optometrist can be sued? Patient is being treated for glaucoma, had a history of ocular histoplasmosis syndrome and choroidal neovascular membrane, and treated with an avastin injection several years earlier. Has moderate cupping, a pressure of 22 and 24. At one point, the glaucoma diagnosis was dodgy, but I wasn't there, so I'm not going to argue that too much. Now, the patient develops advancing field loss, then acuity loss over a 6-month period. Gets referred to ophthalmology, who then refers to a retinal specialist, who then refers to a neuro-ophthalmologist, who diagnoses an optic nerve sheath meningioma. Now, the patient and family are very angry. Now, this is a slam dunk malfeasance, right? It's what we always worry about when we're treating somebody for glaucoma. They got a tumor. All right. Well, I asked the attorney. This is one of my litmus tests. Do you want my opinion, or do you want me to tell you what you want to hear? And she says, no. I don't know anything about I need to know what your opinion is. I don't want to go into a case that's unnecessary. All right. Well, the facts as I see them: patient has multiple diagnoses. Glaucoma, like I said, dodgy. He said, I wasn't there, but had histoplasmosis, had a choroidal neovascular membrane, has retinal vision loss a little bit. All right. Those are confounding factors. Optic nerve sheath meningioma is less than 2% of all orbital tumors. Now you have to convince a jury a reasonable and prudent optometrist should have immediately recognized this rare condition. And yeah, there's some delay in diagnosis, about 6 months, but would it make a difference? I can tell you, I do neuro-op. Bad things happen when the optic nerve is involved. It usually doesn't recover. And her response was, thank you very much. We're not going to move forward with this case. There appears to be no case here. All right, here's another case I was asked to opine. Can we sue? Patient has flashes and floaters. Had symptoms on a Monday, examined, PVD, educated. Gets more symptoms on a Saturday, so the symptoms change. Is seen, out of office hours on Sunday, has a retinal detachment. Now, there's no recording of the encounter. The optometrist got a call, went in, dilated, looked, retinal detachment. And apparently the patient said, oh crap, you have a retinal detachment, which I am sure probably was said. So on Monday, seen by a retinal specialist, he has not eaten anything since midnight, gets a surgical repair. The patient seeks an attorney and wants to sue him, asked to opine against the optometrist. Now, let's take a look at the record. There's only one page here. Everything has been redacted. A lot of floaters, masonry, right eye, started this morning. Okay, here's the examination that he did on the first visit. Now, what is pertinent to me here? We have a little checklist right here where everything was checked off except one thing was intentionally not checked. Incomplete PVD attached to that periphery. Hey, that's pretty good. Dilation, OU, 1% midriasul, 2% neosynephrine. Dilated, BIO, 20, 90 photos. Impression, vitreous detachment, right eye incomplete and symptomatic. Educated RD, follow up in 3 weeks, return sooner, symptoms occur. Pretty darn good. To me, this is pretty darn good. Dilation was done. I know what the meds were. I know what the lenses were. Good description of the condition. Now, there was no charting of the Sunday visit, but the patient shows up, NPO on Monday. He got that information somewhere, so ergo the exam did happen. There was a change in symptoms. That's consistent with the literature. And I asked the attorney, you want my opinion? Or you want me to tell you what you want to hear? He goes, no, I want your honest opinion. I said, in all medical probability, there was not a tear at the time of the initial examination. He goes, thank you very much. Based upon that, I'm going to tell the patient that we should not sue. Cases of optometric malpractice can typically involve obvious negligence and are clearly straightforward. Is that fact or fiction? Greg, this is not a polling question. That could be a chat. If anybody wants to put anything in the chat, do you think this is fact or fiction? Malpractice is obviously negligent. They're clearly straightforward. What do you think, guys?
Nothing in the chat yet, but I'll keep an eye out for it.
Well, if you're not inclined to play on this one, that's all right. We'll move forward. It's fiction. These are virtually never black and white, but they're usually shades of gray. You know, I was retained as a defense expert for two optometrists involving pigmentary glaucoma. The pressure was uncontrolled. Pressures were 32. The patient didn't like their medications. Doctor completely changed the regimen, but scheduled a 6-month appointment. Now, ultimately, the patient underwent multiple surgeries, ended up with light perception vision in at least one eye, and sued 2 doctors for $2 million each. Now, is this something that's black and white? No, I mean, there are shades of gray here. Now, pressure was 32. They changed the medicines, and patient wasn't being compliant, changed the regimen. But, you know, should have been a sooner appointment than 6 months? Well, possibly, but these are things that you can argue with. But like I said, rarely are they black and white. They're mostly shades of gray. Here's another great unfairness. Your actions will impact your employer. If you're sued, your employer will be sued as well. Or if you're an employer, if your employee is sued, you will be sued as well. It's one of the great unfairnesses. It just is. Now, the majority of optometric malpractice involves inappropriate use of therapeutics. Is that fact or fiction? I do want to hear what people have to say on that one. Is it mostly inappropriate use of therapeutics? Is that fact or fiction?
And they're going to weigh into the chat box, correct?
Yes, this is not a polling question.
All right. So we have them rolling in now. We have everyone so far, Joe, has said fiction, 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 fiction.
Excellent, because it is fiction.
Fiction,
The 3
fiction.
main offenders that I see: failure to detect retinal detachment, failure to detect glaucoma, and failure to detect tumor. Now, there's something very common to all of these. Now, when I do this live and I have people, you know, throwing out their ideas, I'm going to make it easy. These are acts of omission, not commission. Not that you did something wrong, is you didn't do something right. So that's the difference there. So these are acts of omission. Now, I will tell you, alleged mismanagement of keratitis is another common one I do see, and that would be an act of commission. But in other words, to look at it, it's failure to listen to the patient, failure to observe the signs, failure to make the diagnosis fit the findings instead of the other way around, failure to do the appropriate tests and follow-up, and failure to make the proper referral. Here's failure to listen to the patient. A 47-year-old male consistently reports hazy vision in his left eye. Was seen by an optometrist 16 months earlier who diagnosed a microesotropia and 20/25 vision in that eye. Fellow eye is 20/20. And I'm not sure if there was an eye turn or not, but that was the diagnosis. 6 months later, goes to another optometrist with the same symptoms of hazy vision. Patient is also now diagnosed with dry eye and has the same acuity. Now, several months later, patient has 20/70 vision with an afferent defect in the left eye and dyschromatopsia in the visual field looks like that. So how often do people with tropes or microesotropia or amblyopia complain about their vision being hazy? They don't. But this is a patient who had a common complaint or a consistent complaint of haziness. This wasn't right. And the appropriate test was not done. Simple visual field. So what should or could have been done? Visual field test. If you don't know, do an OCT, do a visual field. Sometimes you have to go and pull out the big ophthalmoscope and get a CT or MRI. And failure to make the proper referral. Now, who's the best referral in this situation? Another colleague, another optometrist, anybody else in the office. Hey, you know, I've got this patient. You call me up. Yeah, I call you up. I call Greg up and say, Greg, I got this patient who's got really hazy vision. I really can't get him any better. What are your thoughts? And Greg says, well, Joe, what does the visual field look like? And my response is, Greg, I haven't done the visual field. Let me go back and do that. So just get a second set of eyes on it if the patient's not happy. We do that in our practice all the time. Failure to observe the signs. 16-year-old male presents for contact lens fitting. Refraction +1, -1, 20/40 acuity, +75, -0.5, 20/20. Fundus is listed within normal limits. No CD ratio was recorded. He's diagnosed with refractive amblyopia in the right eye and fit with contact lenses. I'm going to say it was specifically refractive amblyopia. At 2-week follow-up, his vision was 2100 and a good fit was recorded. And I can tell you that was about all that was in the chart note for that visit. 1-month follow-up, vision's 2200, but it's still a good fit. And this was about the entirety of the whole chart. Patient's discharged. Comes back a year later for the annual examination, same refraction, now 2400. Fundus is still within normal limits. New lenses were ordered, dispensed, and the patient said, the right eye still is not really that clear. Another doctor picks up in practice picks up an ophthalmoscope and sees there's a retinal detachment. Now I'm looking this over and I said, let this case has got to settle. I mean, the signs are there that the ship is sinking and he's watching it go down. Failure to order the proper test or referral. Thursday morning, 58-year-old male presents with vision loss in the right eye, diagnosed with anterior ischemic optic neuropathy, bilateral, right eye worse than left. Also complains of mild headache and pharyngitis. Now, recommended OCT was recommended and ordered for the following day at another site. Said rate C-reactive protein platelets were written on the chart, but not ordered. On Friday, the OCT is performed by a technician in another office. Saturday, the OD goes in and interprets the OCT, sees disc swelling worse in the right eye than the left, but bilateral, has a come to the Lord moment, I think, and now faxes an urgent request to a PCP to get the serology done ASAP. The problem is it's Saturday and the office is not open. Obviously, nothing happens on Sunday. Monday morning, the message is read. The PCP orders the serology and carotid Doppler, but set for the following Wednesday evening. So we're almost now a week into it. On Tuesday, the patient wakes up with profound vision loss in the left eye, walks into an ER, gets a test done, everything's elevated, diagnosis temporal arteritis, patient legally blind. Now, the fact that the tests were written down on the chart, but nothing was ordered, certainly does look very badly here. Sometimes you just shake your head.
Hey, Joe, hold on one second.
Oh,
hold
sure.
on 1 second.
Yeah.
We have a question. I'm not sure if it's malpractice. We can go back and forth on this, might be able to help. It says, would you get in trouble prescribing 50 milligrams of doxycycline twice a day for a month for a lid lesion treatment because Texas law says only 10 days for orals?
Well, we have some medications in Florida that we can only prescribe for 72 hours. But would you get in trouble? It would not be malpractice, but it may run afoul of your board of optometry, which unfortunately can actually be worse. Sometimes
my comment would be, this would go
good.
to this, someone would, a staff person, I don't think a real savvy patient, a colleague, that's in the area saying, hey, you're going outside your optometric practice act. Maybe an ophthalmologist might know, but this would be handled at the State Board of Optometry. And then the State Board of Optometry would have to rule if you're inside or outside your optometric practice act. And then they would have to come up with some type of disciplinary action that's out there. So I don't think it's really malpractice, as Joe's speaking about tonight, attorneys and patients. You fix the problem, but now are you inside or outside your Optometric Practice Act?
And that summarizes it perfectly, Greg. Sometimes I have to shake my head. I was retained for the defense. Diabetic patient sees an optometrist who diagnoses proliferative diabetic retinopathy in both eyes. Educates warns permanent risk of blindness, must see a retinal specialist within 7 days. Now, unfortunately, this optometrist was not in the network, so he could not enact a referral. So the patient had to be seen by another optometrist in the referral network to get the referral. Sees another optometrist 6 weeks later, who details a completely normal examination. Now, several months later, patient's completely visually impaired from proliferative diabetic retinopathy. So I was asked to defend the case, and I told the attorney, so this is great. Look at it. It's all there. He saw proliferative diabetic retinopathy, warns risk of permanent blindness. You got to see a retinal specialist. He's a little heavy-handed, but it's all right there. This is very easy. The attorney goes, no, it's the other guy. I said, no, thank you. Sometimes you shake your head, part two. I was asked to defend an optometrist who allegedly misdiagnosed or did not diagnose pseudoexfoliative glaucoma. So the attorney calls me. We have a conversation, and I said, I can look at the case. I'm happy to help out and see if I can defend. And they said, okay, we'll send you some materials. And the first thing they send me is an affidavit. They want me to sign that says there is no evidence of glaucoma at this time. Well, I told the attorney, I'm happy to sign it if it's true. Could I see the records? So they send me the records, and one of the first things that I see are these photographs, which detail pretty advanced glaucomatous optic nerve cupping. And I said, I hate to tell you this, but there is evidence of glaucoma at this time. Well, I really can't help you. It's right there. You've got a smoking gun. You've got eyewitnesses. You've got DNA evidence. I mean, you had less in the OJ, just like the OJ trial. There's so much evidence. All right, failure to diagnose retinal detachment. This is probably the most common thing that I see. 50-year-old male has flashes and floaters, goes to his optometrist. Optometrist dilates, does BIO. Sees no breaks, no attachment, records as such. Warns signs and symptoms of retinal detachment, reappoints the patient at a reasonable interval, and dismisses the patient. Okay? All very straightforward. Probably almost, I'm going to say, very good chance anybody on this call tonight probably has seen this exact same thing. Well, a week later, patient has worsening symptoms and vision loss. Calls the optometrist after hours through the answering service. He's out to dinner with his wife, takes the call, listens, and said, okay, I want you to go to this friendly retinal specialist, this fellow that I'm very friends with, good retinal specialist. Why don't you go see him tomorrow morning? Now, he does not record this in his chart because he goes back to dinner, goes home, goes to the office the next day, forgets this ever happened, doesn't put it in the chart. And Greg, that's going to bring me to a polling question. Anything not recorded in the patient's chart is considered not performed. Is that fact or is that fiction?
Anything not recorded in the patient's chart is considered not performed. Fact or fiction? Answers are rolling in.
Mm-hmm.
Looks like the trend is set. Give a little bit more time for some more people to respond. Yeah, I'm going to display it, Joe, to the audience. Let me check. Oh, there it goes. Let me see if there's anything going on with questions. We had some people reply into the chat box, fact. And we have 92% saying fact.
Excellent. Guys, it's fiction. Okay? The old adage, not written, not done, that we learned in the first grade of optometry at school is not true. Okay? Not telling you to be sloppy. We don't want to do that. All right? Everything that you do on a patient's behalf should be in the record, but information can come out other places. It can come out in deposition. Let it happen. All right? Don't try to amend the chart to make it look better. Just let it be. There, just because it's not in your chart, it just is a little harder to prove what you've done, but it doesn't mean it didn't happen. Information can come out in other places. In fact, this was a malpractice case, and in deposition, the treating retinal specialist, said, "Oh yeah, call this doctor who said, come to my office next day." Boom, there it is. It's in the record. So don't try to amend charts afterwards to make things better. There are places where information can come out. Well, this patient did have a retinal detachment and sued the optometrist for malpractice. Now, did the optometrist breach the standard of care? Could he have missed a break? The answer is yes. Could a break have been undetectable even to a good retinal specialist? The answer is yes. Could there have been no break initially and one formed after the examination? Yes. So it's bad outcome, but it's not malpractice. And in my opinion, he met the standard of care. Now, I was hired or retained by the plaintiff's attorney to opine against the optometrist. And the attorney said, "I got another optometrist who will swear on a stack of Bibles this is malpractice." My response was, "Well, give him a call because I'm not going to do it." And he's not bribing me, but he's telling me how much I'm going to bill if this goes to trial. My response was, "No, thank you. I don't believe in this case." And I was summarily fired and was happy to be off the case. Now, I did see all the records, and the friendly retinal specialist was deposed. And they asked, "Could Dr. Optometrist have missed the retinal break?" And the retinal specialist, "Well, yes, it's likely he did. He's not a physician, Now, this may be bothering people out there. You may be getting your neck up over this. Stand down, relax. It's not as bad as you think. Now, I told you depositions are adversarial. They're hostile. They're interrogations. Attorneys are very good. They know what they're looking for. They know what they want. What they want is a legal pot of gold. What is a legal pot of gold? Now, I can tell you, when I'm involved in a case, I'm getting paid for my time. There'll be another person who's also getting paid for his or her time. What they need is to have somebody in the case who is involved in the care, who's not being sued, who's not being paid to say something negative about you. And if they can do that, they've hit their legal pot of gold. That's what they're looking for. They know how to get it. I don't think that this was a bad guy. They're probably still friends. They're probably friends for many years after that. But they get them into a situation, cajole them, intimidate them, push them, prod them to get them to say something that seems relatively innocuous. They know what the attorney knows they know what they're doing. I'm going to give you how it should be. This is a retinal detachment case, another case, same condition, another case with a different retinal specialist. And this is verbatim off the deposition. The attorney, "Do you think that you as a medical doctor, as an ophthalmologist, are better trained and equipped to rule out or rule in a retinal detachment than an optometrist?" Answer, I think optometrists are trained or supposedly are trained in their field to be able to do a dilated fundus exam to diagnose retinal tears or detachments as well as any other eye care professional. Okay, now going for the ego. You believe an optometrist has the same expertise and ability to diagnose a retinal attachment or retinal tear as you do? Response, setting my ego aside, I would say optometrists are trained to evaluate the peripheral retina as well as an ophthalmologist, and that's my answer. Done. Not everybody can do this. Not everybody has that same fortitude. Sometimes, though it is black and white or worse, 55-year-old male has a weed whacker abrasion. He's working, he's rebuilding or fixing his weed whacker. He starts it up in his garage. It hits something on the floor that ricochets off the wall and hits him in the eye. 1 in a million type of situation. Goes to an optometrist who diagnoses a corneal abrasion, treats him for a corneal abrasion. Comes back 2 days later with profound vision loss. He's another optometrist in the practice. A shallow chamber, a pressure less than 5, and hypopyon were all noted. At this point, the doctor felt the patient was having a severe traumatic uveitis from the corneal abrasion and treated the patient with steroids and maybe some other medicines. Now, ultimately, this was a perforating injury. This is a perforation that led to an endophthalmitis. And the patient had several retinal surgeries and ultimately lost the vision in that eye. Now, I was called by an attorney, asked to opine on this case and defend the case. And I told him I was really not interested based upon his description. The attorney cajoles me and says, "Can you at least look at the records and tell me what you think?" So, okay, I'll look at the records. So I look at the records, and they're worse than he told me. I mean, it's just very, very bad. So I call back, and he goes, "So, what do you think? You gonna take the case?" And I said, "No, I'm not. I prefer not to. I find that there is some issues here that make it hard to defend." And the attorney at that point caught me flat-footed. He said, yours is the kindest opinion we've gotten so far. And I have on good authority that you have publicly stated doctors are allowed to make mistakes. Yeah, I did say that one time, didn't I? So he talks me into getting involved in defense of the case. And our defense was they made mistakes. They were wrong. They had a misdiagnosis, and they treated the misdiagnosis properly, but it was still a misdiagnosis. They made a mistake. We admitted right out there they made a mistake. And as expected, during deposition, the opposing attorney hammered on me and beat on me, trying to get me to say it was negligent or below standard of care to not diagnose or consider endophthalmitis. Now, if I use the word negligent or below standard of care or agree with that assertion, it's over. And he beat on me for about 20 minutes. I just rope-a-doped. He came to the realization I was not going to say negligent or below standard of care and gave up. Now, I don't know exactly how it ended. I know it settled. All I was told was everybody was satisfied. But I can tell you, no less than 7 people, 7 professionals, both paid and treating physicians, all said the same thing. They missed a self-sealing corneal perforation. Now, this was not like looking around the corner trying to find a ciliary body melanoma. All right, this was actually looking straight on the cornea, right dead center. Okay, it's right in the middle of the cornea. Here's a self-sealing perforation. And no less than 7 people opined in various times this case that they did not see and diagnose it. Because they did not diagnose it, they fell below the standard of care and they were negligent. And I've heard that in many cases, many, many times. In all medical probability, the retinal break, corneal perforation, whatever it may be, was present at the time of your examination. Because you failed to see and diagnose it, you fell below the standard of care, because the standard of care dictates you would have seen and diagnosed it. Because you didn't, you were negligent. Now, Greg, I don't know what you think about that. This is what I think about it.
Mm-hmm.
It's great. It plays well for an audience, but it's not true. Here is standard of care and negligence. This would be read to a jury prior to deliberation. Negligence refers to a person's failure to follow a duty of conduct imposed by law. Every healthcare provider is under a duty to use his or her best judgment in the treatment and care of his or her patient. to use reasonable care and diligence in the application of his or her knowledge and skill to his or her patient's care, to provide health care in accordance with standards of practice among members of the same healthcare profession with similar training and experience situated in the same or similar communities at the same time the healthcare was rendered. The law does not require a healthcare provider absolute accuracy in their practice or judgment, does not hold them to a standard of infallibility, nor require the utmost degree of skill and learning known only to a few in the profession. The law only requires a provider to have used those standards of practice exercised by members of the same healthcare profession with similar training and experience situated in the same or similar communities at the time the healthcare was rendered. A healthcare provider does not ordinarily guarantee correctness of their diagnosis, analysis, judgment, or the outcome of the healthcare they're delivering. And absent such a guarantee, which we would never give, a healthcare provider is not responsible for mistake in their diagnosis, analysis, judgment unless he has violated the duty previously described. Now, Greg, we can't get into an argument where one patient treats or one doctor treats a patient with travoprost, and I say it should be latanoprost. That doesn't play. All right, but you can't treat an angle closure with blephamide. Yeah. If a patient complains of flashes and floaters, you dilate, you look, you see nothing. All right, you may miss something. It happens. Sometimes it's hard to find some of these tears. All right. That doesn't mean that you are negligent. However, if a patient complains of flashes and floaters and you don't dilate and you don't look, that would be violating a standard of care, and that would be negligent. I'm going to skip over this one. It looks like we're running a little bit late.
So a question did roll in.
Yeah. Yeah.
It says, do you think there will be more doctors being sued now that people go online for telehealth exams? How are those docs protecting themselves when they likely miss things since the patient isn't in front of them to examine?
That's a good question. I don't have an answer. I've never been involved in a telehealth exam yet. My belief is they probably have a fair liability clause that really says what they should do. That this is a limited examination. They are probably going to try to legally protect themselves, but it doesn't mean they can't be sued.
Yeah, and the other thing that I'll add to it, so yeah, they do have, a lot of disclosures at the beginning that this does not replace a live in-person exam, so on and so forth. And then the second part of the question there, they do have a high referral clause in a sense. So if they can't get a good view, if they're seeing something, they're not sure what it is, they basically will make a recommendation, not whether the patient goes, but we have a very low threshold to refer.
Well, I'm going to do this polling question.
Hold
Greg.
on, just rolled
sorry.
in. Would you
Yeah.
likely lose a lawsuit if you only dilate an eye with flashes and floaters and not both eyes for a PVD like exam? Would
The
you
answer is
initially? We got
okay.
more information rolling in, and the second part is initial encounter.
If you just dilate the involved eye, if you don't dilate the other eye, you should have a reason why you did it. Patient declines, patient refuses, because there may be a tumor, there may be something else in the other eye. And as always, when my technicians ask, should I dilate both eyes? My response is, did they bring both eyes with them? The answer is yes. So if I miss something and it was sitting there in my chair, it's hard to argue. You can fight it, but you don't want to be in that situation.
Joe, let me just add to that. What happens if it's an existing patient? I get a lot of existing patients that come in, I saw them, 3 months ago, 6 months ago. They have obvious flash floater in the right eye. I would be inclined, to dilate the right eye. Now, do I look in the back with the left? Does my technician would take a bilateral optomap, wide field imaging, I would look at the left eye. I'd look at the left eye undilated. Let's say the flash, patient said, yes, flash floater in the right eye. Now we do dilate that eye along with taking the wide field imaging. Saw the patient in the last 3 to 6 months. Still, would dilation be, encouraged there?
If you look at him again, I think possibly.
Okay.
Yeah, I mean, you said
I mean, in
said
the left eye. So everything, all the symptoms are in the right eye.
yeah.
The flashes, this and that, blah blah blah. Flash, yeah, patient's right eye, right eye. I saw them 6 months ago. Maybe it was a diabetic exam, dilated both eyes. They come in that day. My technician takes a wide field imaging optomap. I'm going to look undilated in the left eye. I'm going to look at a
Mhm.
photo of the left eye, but we dilated the symptomatic right eye. Are you still advocating that we dilate that left eye?
Now, if you have flashes and floaters, because if they say they have floaters in the right eye, they've got floaters in the right eye. If they have flashes in the right eye, that might be their right visual field. That could be coming from that can be coming from the left eye temporal retina. So flashes are not localizing, floaters are.
Okay.
So flashes
So,
and floaters in one eye, it's probably in that eye.
so I think where Joe's going with some of this out there too is the patient could be complaining like a visual aura that's out there. We know that those happen bilateral, but most of the time the patients come in and say, "Oh yeah, I lost the vision in my left eye." And then that they had a visual aura and it was happening in both eyes. Yeah, it always seems to be more symptomatic in one eye. But if they're there and there, sometimes they come in and they still have the visual aura, and you show them, you cover the one eye and you cover the other eye. So, the point is what Joe's going with here. If they're having flashes or vision loss to the right side or to the right, you might want to do both eyes because it could be something happening in the other eye. Okay,
Anything
we're
else, Greg?
good.
Okay.
Nope, I think we're all caught up.
Here's what I affectionately refer to as a festival of ignorance. Sometimes these were very academically painful to me. 37-year-old females in an optometry office gets referred to an OD/MD center for pterygium surgery, which was done successfully. 1 day post-op, everything's good. 1 week post-op, everything is good. Released back to the optometry practice. Now, patients on steroids pred forte post-operatively. 3 weeks later, comes into the office complaining of some vague blurred vision, sees one of the optometrists who examines the patient, doesn't really have a very good explanation, but also doesn't check the patient's pressure. Next day, the patient's still complaining of this vague blurred vision, calls in again, talks. There's another optometrist in the office. She said, look, patient was just seen here yesterday, wasn't dilated. Get the patient in. As soon as the patient gets here, just dilate the patient. It was just seen here yesterday. So get them in. As soon as they walk in, get them dilated. We'll work the patient in as an emergency. So a patient's dilated and she sees a swollen optic nerve and she gets very, very uncomfortable by that. Tries to refer, neuro-ophthalmology is not available, neurology is not available. Now, they also didn't check a pressure in this office, but she does consult or contact a friendly retinal specialist who agrees to see the patient the same day. So sends the patient over the same day. He measures the pressure. Pressure is 49.5, not 49, not 50, 49.5. He sees a swollen nerve. He diagnoses optic neuritis and orders an MRI. And the MRI comes back normal because it's not optic neuritis. But he still is diagnosing optic neuritis. And he also correctly diagnoses a steroid-induced pressure rise. Now, what does he do? He injects a steroid into the eye to treat optic neuritis. And I can tell you, intravitreal steroid injection is not a treatment for optic neuritis. All three, both optometrists and the retinal specialist, were sued for missing steroid-induced glaucoma. Now, does any glaucoma cause a swollen optic nerve? The answer is no. What did she have? She had a non-arteritic anterior ischemic optic neuropathy. I was in defense of this case. I had the photos. I had the fields. And nobody even considered this diagnosis until I wrote a 5-page dissertation on it. I can tell you they had their expert witness who was an ophthalmologist. He might have been one of the treating ophthalmologists. This was in his deposition. And he was opposing these three doctors. Any delay in treatment was significant because the glaucoma progressed at an unusually rapid rate, and even a delay by an hour impacted the outcome negatively. Now, I think we all know no glaucoma progresses by the hour. Dyspallor is common in glaucoma. Well, we know it's not true. Glaucoma commonly happens with small cups. Now, glaucoma is a disease of cupping. What's the disease of non-cupping? Non-arteritic ischemic neuropathy. When the IOP is very elevated, it often causes a swollen optic nerve. I've never heard of that before. And you never consider an ischemic neuropathy in a patient under the age of 70. I actually asked to get a copy of this person's CV because I really seriously doubt he went to medical school. Let's see, how much time do we have left, Greg?
You have 7 or 8 minutes.
I'm going to skip kind of over this, and I'm going to talk about if this happens to you, how do you survive the deposition? How do you survive this? Here's the most important thing to remember. It isn't personal, it's just business. It's what they do. Like you doing an eye exam, they sue doctors. It's what they do. It's not personal, it's just business. They may even feel bad for you. Now, the question is, am I being sued? You're going to get subpoenaed for your records all the time. It doesn't mean you're being sued. It can be accidents, disability, can be anything. But send them. Send them complete, unaltered. Don't worry about it. Now, if you get a letter, a notice, the intent to litigate letter, notice of intent to litigate, it says that in the very beginning, you are being sued. There's my email, my private email, and my cell phone number. If this ever happens to you, call me, contact me. I will talk you off the ledge. I've done it many times. The notice of intent to litigate immediately will try to beat you into submission. They don't mention your care or your exam. They talk about your negligence. It will say in there, prior to your negligence, as a result of your negligence, was there anything subsequent to your negligence? Don't ever respond to this yourself. Contact the insurance company. They will get an attorney for you. That attorney will be on your side. You know, I talked with several attorneys. They get angry. They quote unquote they say, "I don't like it when my doctors get sued." They get testy over it. Now you have to be honest. You can't withhold information. You can't say that's not my signature at deposition. That doesn't occur. It all comes in the depositions. The attorneys representing all parties are going to be involved. There's a court reporter and a videographer. Thankfully, these are now done on Zoom for the most part. There's no judge or jury. Now, for me, a short deposition, 90 minutes. I think my last deposition, 5 hours. No judge and jury. It's just a fact-finding mission. You don't volunteer any information. You're not going to convince them they were wrong to sue. You're not going to win in deposition, but you can lose in deposition. They always insist on home field advantage, but nowadays we're mostly doing these on Zoom. And you can attend other people's deposition. If you're being sued, you can go to anybody's deposition and sit there. There is a certain intimidation factor involved. It all is still the deposition. The trial is nothing more than a performance. This is not My Cousin Vinny. Nobody is bursting through the back doors of the courtroom, flashing a piece of paper saying, "I've solved the case." It doesn't happen. The trial is just a performance. The show's been written, it's been rehearsed, hair and makeup. The audience is the jury. There's no smoking gun. Everything comes from the deposition. It's the script. If it isn't in the deposition, it cannot be used at trial. Everything. In fact, they will probably go word for word off the deposition. Like I said, it's not My Cousin Vinny. It's not what you see on TV. It's not what you see in the movies. Just answer the questions. You have to answer unless you're instructed by your attorney not to. The attorney will object throughout your testimony. You still have to answer, because they're just objecting to how the question is being asked. And don't try to educate the plaintiff's attorney. You might give them some information they would not otherwise have had. And try not to give great testimony. You'll have your chance in court, but be prepared and be professional. Beware of wolves in sheep's clothing. The deposition is adversarial. Some will try to intimidate you, others will kill you with kindness. They're still the enemy. They want information to use against you. Always keep up your guard. Even if you're in deposition, if you're on Zoom or you're in a conference room, you're all sitting, it can be very, very amiable. It's all part of the game. They're trying to get your guard down. If you get too comfortable, think, hey, this isn't really not going so badly. You might agree to something that's medically ridiculous. You can always take a break. I've always said, deposition is like driving in the snow. Not a blizzard, but just in the snow, all right? Both hands on the wheel. You're not on your phone. You're not fiddling with the radio. You're paying attention. If you do that, you're going to arrive alive. Always look in the mirror. Your appearance and demeanor is going to be as important as your testimony. You got to be neat. Don't be angry. Don't get hostile. Don't be condescending. They're trying to do that. They've got a very limited repertoire. Their approach is optometrists are just failed ophthalmologists. They're failed physician wannabes. They will go after you, after your ego. They'll say, "Doctor, you didn't go to medical school, right?" I remember, Greg, I was being deposed. The plaintiff's attorney was actually an attorney and an ophthalmologist. He was an ophthalmologist who went back to law school and was practicing law. And he was talking, and he starts to, he knows who I am. He knows all about me. And during the deposition, he said, "Dr. Sowka, now, doctor, you're not a medical doctor, right? You didn't go to medical school. You're not a medical doctor, right?" My response was, "Oh, no. I'm an optometrist. Please don't insult me." So when I went to school, there's only 23 optometry schools, but 172 medical schools. And I got in one of the optometry schools. "No, I'm an optometrist. Please, don't insult me." And they're going to ask questions to try to get you to seem dishonest, okay? It's not personal. It's just business. I remember one time, Greg, I was actually in trial. It was a pediatric uveitis case. I was defending the optometrist. It wasn't a very strong case. The plaintiffs didn't have a very strong case. It was parents who were negligent, and they were looking to deflect blame and blame the optometrist. But I remember I was I was in the gallery waiting to be taken to the stand. There's no jury there. The attorney comes in, very brusque sort. He sees me, plaintiff's attorney, sits down next to me and said, hey, good to see you. Good, how you doing? How you doing? Good to see you. Good to see you. Look, case is what it is. And it's not more, I can't make it more than it is. It is what it is. Look, I'm gonna be brief. I'm gonna go off your deposition. In fact, I'm gonna go word for word off your deposition. No hijinks. Straightforward. No hijinks. It is what it is. Good to see you. Okay. Jury comes in. I'm sworn in. He is sighing, pounding the lectern, gesticulating. Can't believe he has to deal with the ilk of me. Portrays me as a scourge of the profession. I do my testimony. I'm walking out. I walk by him. He goes, "Hey, good job. You did a good job up there." I mean, he friended me on Facebook. He connected me on LinkedIn. It isn't personal. It's just business. Always know what you're answering. Make sure that, if the questions are confusing, ask them to be repeated or rephrased. Usually they'll be read back. Don't be intimidated into answers the attorney wants. They may not be, there's very few absolutes in life. But you must answer yes or no. You can explain yourself after answering, but you can't start with a soliloquy and try to explain yourself when it's a yes or no question. You have to say yes or no, then you can explain yourself. And there are some red flags. Would you agree that, or is it a fair statement? Usually they're trying to give you a broad preposition that it's kind of tough to answer yes or no. And they're trying to elicit material to use against you. You got to let the attorney finish questions before answering. you need to understand the question before you respond. And a court reporter can only transcribe so fast. You can't say uh-huh or uh-uh. You have to say yes or no. Can't shake your head up and down or side by side. That doesn't come out. And probably the biggest thing that people have issues with is they talk over one another. That's where depositions go sideways. Sometimes you can't remember. Facts occurred several years ago. I can guarantee you probably won't remember the examination where this all occurred. You can refer to your records during questioning. They will all be there. If you remember something, you say it. If you don't remember, you say it. But you can't guess. You can't speculate. You can't use the word speculate. If you use the word speculate, everything after that will be stricken. Hypotheticals are only to be used against you. Sometimes you can't answer a hypothetical question. Make sure you agree with the entire hypothetical. May say, Dr. Caldwell, would you agree hypothetically that the earlier you diagnose cancer, the better the patient's prognosis? Sounds pretty reasonable, right? Well, there are some cancers that are uniformly fatal, so that is not a hypothetical you can really answer. It's not a crime to meet with an attorney. They will try to intimidate you that you shouldn't be doing this, but of course you should be meeting with the attorney, and nothing is off the record. Keep your mouth shut. Tell the truth. There are very few cases that can't be defended on the facts, and there are very few cases that can be defended if the doctor is caught lying. Hold to your opinion. Sometimes they will try to make it sound like you are being dishonest. If they don't like your answer, they may say, "Are you telling us under oath? Is it really your sworn testimony?" Well, your answer is your answer. If you ask repeatedly, you repeatedly give the same answer. You rope-a-dope them. It won't go for long. Your attorney will stop that. But you can say yes 3 times. They bully you into saying no once. That's the answer they're going to go with. And prepare. You'll always have a chance to explain yourself in a court of law. Once something is said in deposition, it is written in stone, and a skilled attorney can get a good physician to agree to some medical impossibilities. He can defend virtually anything. So in conclusion, optometric malpractice is very uncommon. It's very rare. But if you see as much as a patient, you've got the potential. It's a fact of professional life. You will get through it. It's not the end of your life, not the end of your practice, not the end of your career. You will get through it. If this ever happens, reach out. I will talk you off the ledge. And remember, it isn't personal. It's just business. So with that, Greg, I'm going to stop sharing. I think we're right out of time. And that'll be it.
Yeah, good job. I just wanted, before we wrap this up, if you see the little red dot there where it says survey, you can open up the survey and start answering the survey. You don't have to wait 5 minutes for the email to go out. Joe, I just looked. I don't see any further questions.
Okay, I don't think I do either.
You're getting your virtual round of applause, some claps, some thank yous, and I'm going to say thank you. Not an easy topic. Obviously, you've done over 150, 200 cases, and it shines here. Thank you for doing this. Maybe not the clinical type of education, but well-deserved and well-needed education out there for our audience. So thank you for doing it.
And thanks for running this, Greg. Makes it a whole lot easier for me.
No problem. So we're going to end the education, and that was Dr. Joe Sowka doing Mitigating Medical Mishaps. It was a synchronous virtual course.